I'm here with Dr. Christine Suess, a comprehensive ophthalmologist who is also acting chief of ophthalmology at Cornwall Community Hospital. She has been in community practice for over 10 years. Dr. Suess, it's great to have you.
Thank you.
Can you start by telling me a little bit about your practice in Cornwall and the number of and types of patients you are currently taking care of?
In Cornwall, I work in an eye care center. I am a comprehensive ophthalmologist, and I'm married to an optometrist, and he has two brothers and his father and sister who are also optometrists. So we actually work together, although we run our practices separately. In my office, I'm able to provide comprehensive eye care as a result of that, and I am able to focus mainly on the medical and surgical treatment of the eye. I serve an area of over 100,000 people, and I have about 3,000 active patients.
Wow, so it is quite a big practice with a lot of synergy in the office.
Yes, yes.
Amongst these patients, what are the most common types of eye conditions that you are seeing in your practice?
The most common diseases I see are cataract, glaucoma. I do see a lot of macular degeneration as well as blepharitis and dry eyes.
For our listeners, cataract, glaucoma, and macular degeneration are three out of the four leading causes of blindness in Canada, diabetic retinopathy being the fourth.
That is correct.
Amongst these patients, then, I imagine there is a considerable amount of diagnostic imaging that needs to take place in order to help diagnose and manage these patients. Can you comment about what sort of diagnostic images these patients undergo in your practice and how it is utilized?
Sure. There are several tests that we do as ophthalmologists. As you know, we have quite a bit of equipment in order to perform just a routine eye exam. So some of the equipment we use to test for these diseases include optical coherence tomography, which is called OCT for short, a visual field testing, as well as we do what's called pachymetry, which is measurement of the thickness of the cornea. We also do some other tests such as measurement of the eye prior to cataract surgery. It's called ultrasound biomicroscopy, and there's also a more advanced test called the IOL Master, which uses an optical measurement of the eye, which seems to be more accurate. And I also do another testing, which is called corneal topography, which is a topographical map of the cornea, which can identify certain diseases of the cornea.
Recently, the government has made some changes and reduced reimbursement for some of the diagnostic tests, particularly OCT, or optical coherence tomography, you mentioned, as well as Humphrey visual field testing. Can you briefly discuss how this might affect patient care in your practice?
Both of those tests are very important in the diagnosis and management of glaucoma. And the cuts that the government has instituted will limit access to these vital tests because currently I am performing these tests at a loss at the current fee the government has set. I do not know how long I will be able to continue to do this. I personally decided to continue to offer the test despite the fact that I am losing money doing the test because I feel it's an important test in the management of glaucoma. If my OCT machine or my visual field machine breaks down, I may not be able to repair the machine. I may no longer be able to perform the test here in my office, and patients will have to travel elsewhere for the test because I'll make sure they still have the test. It just won't be able to be provided by me. This worries me that my patients will be inconvenienced by this and may actually lose vision unnecessarily if they do not have timely access to this important test. I'm also concerned about my patients who are being treated for macular degeneration and other retinal diseases by my retina colleagues. These patients require regular OCT tests in order to determine if they need an injection of a drug into their eye to treat their disease. The limits the government has imposed on these tests make it difficult for the retina test to perform them.
It sounds like you are maintaining a good standard of care by still allowing your patients to have access to the test, so long as you're able to keep the machine running.
That's exactly it.
Based on what you've said thus far, a Humphrey visual field test or an OCT test is considered standard of care in the diagnosis and management of conditions such as glaucoma and macular degeneration. Is that correct?
That is exactly correct. In fact, the Humphrey visual field is still to this day considered the gold standard for managing glaucoma, and OCT is fast becoming the gold standard for managing macular diseases such as macular degeneration and diabetic retinopathy.
Right. You mentioned you are heavily involved in cataract surgery. and that is one of the major conditions that you see in your practice. Can you tell me how many cataracts you are currently operating on per year?
Sure. I do over 600 cataract surgeries per year, and I have a special interest in providing patients with advanced technology lenses during their surgeries to allow them to not have to wear glasses after their cataract surgery.
That sounds great, but the government has actually made some recent changes that you must be aware of with respect to anesthesiologists and their ability to be present in these cases. They recently reduced the reimbursement for ophthalmic surgeries such as cataracts and the anesthesiology fee for those cases also. Now, are your surgeries performed in a hospital?
Yes, I perform my hospitals locally here at the Cornwall Community Hospital.
So is an anesthesiologist currently present in your cataract surgery cases?
Unfortunately, not all the time anymore as a result of these cuts. What has happened is I had a long discussion with my department, and they actually weren't going to cover my surgery anymore unless absolutely necessary. But this became very difficult with the type of patients I have. So currently, they are allowing me 1 day a month of an anesthesiologist. So this means that the most vulnerable patients who require anesthesia have to wait longer than the other patients who can undergo minimal sedation.
I see. That does not really sound ideal for the patient then, does it?
No, it's not.
What are your thoughts in terms of the role of an anesthesiologist in cataract surgery? Is it really necessary?
Absolutely. Cataract surgery has seen great advances over the past few decades. Currently, cataract surgery is performed under topical anesthesia with some IV or oral sedation to keep the patient comfortable during the surgery. Some patients choose to have no sedation, which is the exception. An anesthetist is the person who provides the sedation and monitors the patient's vitals and makes sure they're comfortable during the surgery. I feel that they play a vital role in the success of cataract surgery because as a surgeon, my attention is on performing a successful cataract surgery, not trying to make sure that the patient is comfortable and does not move.
Based on what you said, it sounds like the wait list for patients requiring sedation with the presence of an anesthesiologist will grow.
That is correct.
What advice would you offer to the community of patients who are listening to this broadcast regarding the current and future delivery of eye care in Ontario?
I would like to advise patients to speak with their eye physician about how the cuts will affect their care. They should get involved in any way they feel they can. The eye physicians and surgeons of Ontario have been working hard to provide the best care they can in less than ideal circumstances. I'm afraid that if people don't speak up against these cuts, then wait lists for surgery will become unbearably long. Patients will no longer have their eye care provided close to home, and this burden will potentially result in people losing vision.
That is really an important point that was just made by Dr. Suess. Dr. Suess, based on what you've said today, it sounds like OCT and visual field testing are considered standard of care for the management and diagnosis of retinal disease and glaucoma. And also having an anesthesiologist in the room for cataract surgery is considered safe and best practices for the patient.
That is correct.
Dr. Suess, I'd like to thank you for taking the time out to speak with me today and educating our patients in Ontario about the evolving nature of healthcare in Ontario.
Well, thank you very much. I really appreciate the opportunity to discuss the issues surrounding the recent government cuts to eye care. I hope people will listen and have a better idea of how the government has put our patients' eye health at risk by imposing the reckless cuts to eye care and not negotiating better ways to find savings with Ontario's doctors.